So I want to put the calcium into perspective and not make it too complex around showing very, very complex cases, because I don't think they convey enough. I want to give you the philosophies around calcium just as we sat there and all of us experience, we're giving you the philosophies rather than complexities. So let's make it simple for you. Severely calcified lesions, and we've just been discussing the devices around treatment of calcified lesions, and predominantly they revolve around cutting, scoring balloons, revolve around the ultra high pressure OPN NC balloon. And I hope that you have the OPN balloons here. Yes, you have the OPN balloons. They revolve around atherectomy devices, rotational and orbital atherectomy, as you've just heard. Intravascular lithotripsy, which has been introduced into Bangladesh over the last year, and of course laser atherectomy in certain instances. I'm going to put everything into perspective and make you understand that calcium is one of the nemesis for interventional cardiologists. Every time we see a heavily calcified vessel, we say, oh my God, why me? Why do I have to do it? Can't somebody else take it up? I think I'm going to have loads of problems, because clearly associated with difficulty in getting balloons down, difficulty in getting stents down, imaging, inadequate results, which translate into complications at the time of the procedure, well recognized perforations, and subsequently adverse outcome both of stent thrombosis and in-stent restenosis. Yet, as we do older and older patients, as we do more complex patients, as you just saw there with comorbidities, we have a greater proportion of patients, and some of us actually end up doing 20 to 25% of our patients are complex, heavily calcified. And by the way, required device synergy. This is not just one tool in itself, device synergy. As far as imaging is concerned, we got the two important modalities, and that's IVUS and OCT. And what you got to realize is IVUS picks up calcium far more efficiently than OCT. However, you're not able to calcify that calcification, because you will see only blankness behind the calcium, and therefore the thickness of calcium is well identified on OCT. And of course, while there are scoring systems designed for both OCT as well as IVUS to understand it, you should remember this scoring system of fives, which is greater than 5 millimeter depth, greater than 50 degrees, 50% arc, which means greater than 180 degrees, and I say greater than 270 degrees, and greater than 5 millimeter calcium length actually signifies under expansion of stent if an adjunctive calcium modification tool is not used, and therefore predicts stent expansion and poorer outcomes. Well, having said that, let's just understand the devices. Of all the devices that we have in our hands, I think I could talk hours about this, and I won't. We'll perhaps do it in our discussion. But yeah, they're less expensive, more expensive. They've got larger learning curve, smaller learning curve. They're safe and not safe. But at the end of the day, you need to know all the devices to actually get your best results from heavily calcified vessels, because you just see it's adjunctive use of devices which matters. Important technical considerations, and just indwell into your mind. Support, support, support. Guide catheter 7 French as far as I'm concerned. Support and extra support wires, because you're going to not just deliver devices, you actually need to bail yourself out of complications as well, and that may mean covered stent, balloon changes, and so on and so forth. Guide extension catheters are going to be required, you like it or not, so be ready for it, and long sheets on occasions to provide you the best backup. You have proximal calcified tortuosity. Therefore, you'll need low-profile deliverable stents, shorter stents, guide extension catheters, occasionally the wiggle wire and the buddy wires, and of course, scoring and cutting balloon, ultra-high pressure balloons, rota IVL imaging. But the single last point is all you need to carry home. Irrespective of whatever you do, do not implant a stent till the lesion is fully dilated in 2 orthogonal projections. That is a single thing that you have to do after every calcium modification. After anything what you do prior to implanting a stent, make sure that your balloon expands in 2 orthogonal projections. Otherwise, you'll be left with an under-expanding stent. This is a sort of Guide catheter support you may need for complex, failed, heavily calcified lesions that had failed somewhere else came to me. Obviously, the guide catheter support at another place was a real problem and could not, that distal lesion could not be tackled. And of course, what it involves in this upward takeoff is a long sheath, which you'll see here, an AL1 guiding catheter, a Grand Slam extra support wire, and a guide extension catheter, and still a balloon would not cross that distal calcified vessel, which of course the wire did cross and had to be rotablated. And then of course it was nodular calcium all across, which is treated. So I'm going to just talk about, where's the timer? Oh, it's here. Oh, that's going down pretty fast. Tips and tricks beyond usual for each device, and I would love to. So rotablator, anybody wants to learn the tips and tricks? It's later on today in the technical village, and I'll talk to you in the technical village about tips beyond the usual. But let me talk about, and I'm going to talk beyond the usual and not the simplest thing. For scoring and cutting balloons, one single full stop, not meant for heavily severely calcified lesions. Just forget it. It's meant for mild, moderate calcification. It's great for fibrotic lesions. It's great for osteal lesions. It's great for in-century stenosis prior to drug-eluting balloons. It's good for mild to moderate calcification. It's not bad after rotational atherectomy, what we call rotor cut, which there is enough data to say you can get better stent expansions after routing it in after rotational atherectomy, and little use in current generation of severely calcified lesions that you just saw. Best practice points for ultra high pressure NC balloons. You must understand that these balloons do grow. The good thing is they extend up to 35 atmosphere pressure, can go up to 40 atmospheres. Beyond 40 atmospheres, they will start bursting. If you actually compare them to a non-compliant balloon, your standard non-compliant balloon, be it Trek, be it Euphora, be it any, you actually see that there is an expansion of OPN balloons as well, which is 0.02 millimeters less than what happens to a non-compliant balloon at lower atmospheres. The only thing is, look at a 3.5, at 30 atmospheres it's 3.85, at 35 atmospheres it's 3.91, it's grown by 0.04. You must keep a track of that in your own mind. It's not as if it doesn't grow. So you need to know the vessel size prior to using ultra high pressure balloons. This is what I was talking about, sorry, it's right here, this is what I was talking about. See if the comparison, it only grows slightly less than your non-compliant balloon, so keep in mind that very factor. So NC balloons can go up to 30-40 atmospheres. I have regularly used them at 45 and 50 atmospheres. They will rupture at above 40 atmospheres. It's safer than NC balloons, are the best form of non-compliant balloons, but they grow. So great for unyielding lesions, post-rota unyielding lesions, post-IVL unyielding lesion, under-expanded stents where you have not achieved MSAs. Don't chase, I think I'll address that, heavily calcified lesion as standalone prior to implantation of stent and for device synergy, but know the vessel size. Use a half-size, lesser OPN balloon to high pressures than the vessel size on imaging, and then only go up. And this is what that relates to. Imaging is a must to understand the vessel prior to using ultra-high pressure OPN balloons. Okay. When you think rota, just do it. Okay. That's very simple. I'll talk to you about halfway rota and guide wire biases when you visit me in the rota workshop, and I'll tell you my 10 commandments of rotational atherectomy. So I won't show you that, and I will, if you just want a brief of what you will see there, then you will see something like this in a heavily calcified vessel, and you learn how to rotablate this extremely heavily calcified last remaining vessel in a person with 25% ejection fraction and a failing heart, and how you have to actually tackle such vessels. But not to take you anything, I just want to give you one important message, so I'm just moving away from that to intravascular lithotripsy. I think my one or two cases will demonstrate to you. This is the best practices, and if you want to read the best practices, go to the CCI, where you'll see my editorial on intravascular lithotripsy around 2021. Deliver all the pulses, even if you feel that your lesion has done well, deliver all the pulses, don't take it home. Predilate the lesion prior to putting your IVL, so that the IVL crosses easily and works on the deep calcium. Distal to proximal, because it's a high profile and the guiding catheter will suck when you actually, and it's very difficult to position it from proximal to distal once it's been expanded and then deflated. And by the way, this is another trick to learn. This emitter is at 2 millimeters from the proximal end. It's the emitters which give the maximum pulse. So if you have got a heavily calcified eccentric or nodule calcium, actually place the emitter on that and deliver the pulses. So you're placing the balloon eccentrically and deliver more pulses at the eccentric lesion. Look for IVL balloon expansion in 2 orthogonal projections. This is the sort of lesions we sometimes have to do. A 77-year-old male, extremely ugly looking lesion, nodular, heavily calcified. But we do, let me not take you through that. We can actually discuss this sometime else, except the fact that these are treated with rotational atherectomy, IVL, followed by OPN, which was done under IVS guidance to finally, so triple modality, bifurcation stenting, and finally you get a good optimal result on intravascular imaging. But it needs use of rotational atherectomy, use of non-compliant balloon, use of intravascular lithotripsy, followed by stent implantation, followed by use of IPN to get these results. And just one final illustrative case. I think, did it not come up here? I don't think it came up here. That was an IVL case. Can I just show that? And I'll tell you why. It's a simple case, but it's illustrative. So I think I will need to go back. What are the changes I made recently haven't come here. Can we just exit this? And I just want to show a single case. It won't take me a minute, but it's still very important for you to understand. So I'm going to escape on this and see whether I can get that. Yeah, and I'll get that case. Here is a very interesting case. This is simple. 59-year-old diabetic, previous mid-LED stent, and you can actually see that the stent is there, and you've got a very discrete lesion. Now, this is actually a fellow's lesion. This is you would just tell the fellow to do this case and move on, except that there is some calcification you see. And if there's some calcification, you see, oh, as you said earlier, there's a calcification, there's nothing big deal about it. Anyway, do an OCT. Yes, there is circumferential calcification. You see it right here. The thickness, you actually see that it's close to a millimeter there. And so it all fits in with saying device modification. Yeah, it could be rotational atherectomy. Why not IVL? This is thick calcium, so why not IVL? So you have a 3 millimeter. You've actually measured everything. You've done the right thing. 3 millimeter IVL, 40 pulses delivered. And it's beautiful. Just look at.
Guys.
Said we've heard him enough, he needs to move out now. Anyway, the 4th cycle, look at the expansion, absolutely great. So what's the job done? I look at it with eyes, we always say image, you'll see fractures, the lesion will dilate, you put in the stent, it's a great result. So here I go, cuts made by IVL, and I'm telling this to my fellow, now do this. See the cuts, they're beautiful. Just now put in a stent. So, and I'm standing by, and he puts in the stent, and yes, he puts it beautifully, 18 millimeter 2.75, then a 3 millimeter balloon expanded to 18 atmospheres, and it looks great. So I actually walk away. I walk away and I say, okay, let's have the final shots, and he does this final shot, and he finds a horrendous residual stenosis in an helioprojection. We had done IVL, we had seen an expansion, we had done imaging, we'd seen fractures. That single thing I told you, look at the balloon in 2 orthogonal projections prior to stent implantation, wasn't done, and this is that in the second view. Well, after that we had 4 pulses remaining, 4 cycles remaining, so more IVL delivered. After that, a 3 millimeter balloon at 26 atmospheres still doesn't take away the residual stenosis. It's still there. It's eccentric. I should have delivered all my 80 pulses out there had I seen it in the other projection. And then again, I put in an OPN. I look at, and this is the biggest learning. You have to start then looking at MSAs. You cannot rupture the vessel, and the MSA is small, 3.82 on an OCT at that point. What looks in a cranial view as overexpanded stent is only a 3.82 vessel. Undersized, extremely undersized. And then I go with an OPN to 40 atmospheres. I finally look at the MSA, and I finally get the MSA to beyond 5, and I say, thank God, even though on the ariocaudal projection there looks a residual stenosis, I'm done. And that is the message I wanted to give you. The final result is still better. It's overgrown in the other side. You look at the MSA after that. do not chase a residual stenosis, but chase the MSA beyond a particular point if you don't want to have complications. So finally, to me, what is important is the balloon expanded in 2 orthogonal projections prior to stent implantation, and if there's a residual stenosis, look at the MSAs, and if you achieve 4.5 OCT, and I say 5 millimeters OCT, they say 5.5 on IVUS, I would say 6 on IVUS, you're actually done at that particular point. Thank you very much.
Thank you, Dr. Seth, for that masterful lecture.